About fractures. A fracture is a disruption or break in the continuity of the structure of a bone. Although traumatic injuries account for the majority of fractures, some fractures are secondary to a disease process, such as pathological fractures from cancer or osteoporosis. LG is a 23-year-old man brought to the ED following injury to his right arm during a rugby game. A bone in his forearm is protruding through the skin. Clue number 1. EMS immobilized the arm at the scene, and LG rates his pain as a 9 on a scale of 0 to 10. How would you classify this fracture? Well, it's an open fracture because the bone is protruding through the skin. It's most likely a complete fracture as the break is completely through the skin. It's also displaced. Fractures can be classified as open, formerly called compound, or closed, formerly called simple, depending on communication or non-communication with the external environment. In an open fracture, the skin is broken, exposing the bone and causing soft tissue injury. In a closed fracture, the skin has not been ruptured and remains intact. Fractures can also be classified as complete or incomplete. Fractures are termed complete if the break is completely through the bone, and incomplete if the fracture occurs partly across the bone shaft, but the bone is still in one piece. An incomplete fracture is often the result of bending or crushing forces that are applied to the bone. Fractures are also described and classified according to the direction of the fracture line. So, for example, there's linear, oblique, transverse, longitudinal, and spiral fractures, as you can see in this graphic. A is a transverse fracture, in which the line of the fracture extends across the bone shaft at a right angle to the longitudinal axis. B is a spiral fracture, where the line of the fracture extends in a spiral direction along the shaft of the bone. A green stick fracture is an incomplete fracture with one side splintered and the other side bent, just like a green stick. Comminuted fracture is a fracture with more than 2 fragments. The smaller fragment appears to be floating. An oblique fracture is a fracture in which the line of the fracture extends in an oblique direction. A pathologic fracture is a spontaneous fracture at the site of a bone disease. And a stress fracture is a fracture that occurs in normal or abnormal bone that is subject to repeated stress, such as from jogging or running. Finally, fractures can be classified as displaced or non-displaced. In a displaced fracture, the 2 ends of the broken bone are separated from one another and out of their normal position. Displaced fractures are usually comminuted, meaning more than 2 fragments, or oblique. In a non-displaced fracture, the periosteum is intact across the fracture and the bone is still in alignment. Non-displaced fractures are usually transverse, spiral, or green stick. For what other clinical manifestations associated with a fracture will you assess LG? Well, you want to assess for decreased function, inability to use the arm, swelling, and bleeding from the soft tissue damage. The clinical manifestations include immediate localized pain, decreased function, and inability to bear weight on or use the affected part. The patient guards and protects the extremity against movement. Obvious bone deformity may not be present. If a fracture is suspected, the extremity is immobilized in the position in which it is found. Unnecessary movement increases soft tissue damage and may convert a closed fracture to an open fracture, or create further injury to adjacent neurovascular structures. LG asks you how long it will take for his bone to heal. You quickly review the fracture healing so that you can answer his question better. Describe the 6 stages of bone healing. Okay. Bone goes through a complex multi-stage healing process termed union that occurs in the following stages. Fracture hematoma. When a fracture occurs, bleeding creates a hematoma, which surrounds the ends of the fragments. The hematoma is extravasated blood that changes from a liquid to a semi-solid clot. This occurs in the initial 72 hours after the injury. Stage 2 is granulation tissue. During this stage, active phagocytosis absorbs the products of local necrosis. The hematoma converts to granulation tissue. Granulation tissue, consisting of new blood vessels, fibroblasts, and osteoblasts, produce the basis for new bone, substance called osteoid, during the 3 to 14 days post-injury. Callus formation is next, as minerals, calcium, phosphorus, and magnesium, and new bone matrix are deposited in the osteoid. An unorganized network of bone is formed that is woven about the fracture parts. Callus is primarily composed of cartilage, osteoblasts, calcium, and phosphorus. It usually appears by the end of the 2nd week after injury. Evidence of callus formation can be verified by X-ray. Ossification of the callus occurs from 3 weeks to 6 months after the fracture and continues until the fracture has healed. Callus ossification is sufficient to prevent movement at the fracture site when the bones are gently stressed. However, the fracture is still evident on X-ray. During this stage of clinical union, the patient may be allowed limited mobility or the cast may be removed. Stage 5 is consolidation. A callus continues to develop, the distance between bone fragments diminishes and eventually closes. During this stage, ossification continues. It can be equated with radiologic union. Radiologic union occurs when there's X-ray evidence of complete bony union. This phase can occur up to a year following injury. And lastly is remodeling. Excess bone tissue is reabsorbed in the final stage of bone healing, and union is completed. Gradual return of the injured bone to its pre-injury structural strength and shape occurs. Bone remodels in response to physical loading stress, or Wolff's Law. Initially, stress is provided through exercise. Weight bearing is gradually introduced. New bone is deposited in sites subjected to stress and reabsorbed at areas where there is little stress. In this graphic, you can see in A, bleeding at fractured ends of the bone with subsequent hematoma formation. Next is organization of the hematoma into a fibrous network. C is invasion of osteoblasts, lengthening of collagen strands, and deposition of calcium. D is callus formation, where the new bone is built up as osteoclasts destroy dead bone. And lastly, remodeling is accomplished as excess callus is reabsorbed and trabecular bone is laid down. Many factors influence the time required for complete fracture healing, including displacement and site of the fracture, blood supply to the area, immobilization, and internal fixation devices such as screws and pins. The ossification process may be arrested by inadequate reduction and immobilization, excessive movement of the fracture fragments, infection, poor nutrition, and systemic disease. Healing time for fractures increases with age. For example, an uncomplicated midshaft fracture of the femur heals in 3 weeks in a newborn and in 20 weeks in an adult. Smoking also increases fracture healing time. Fracture healing may not occur in the expected time, and this is called delayed union, or not at all, called non-union. In delayed union, fracture healing progresses more slowly than expected. Healing does eventually occur. In non-union, the fracture fails to heal despite treatment. There's no X-ray evidence of callus formation. In malunion, the fracture heals in the expected time but in an unsatisfactory position, possibly resulting in deformity or dysfunction. Angulation, the fracture heals in abnormal position in relation to midline of the structure, which is a type of malunion. Pseudoarthrosis is a type of non-union occurring at a fracture site in which a false joint is formed with abnormal movement at the site. Refracture is a new fracture occurring at the original fracture site, and myositis ossificans is deposition of calcium in muscle tissue at the site of significant blunt muscle trauma or repeated muscle injury. The overall goals of fracture treatment are anatomic realignment of the bone fragments, called reduction, immobilization to maintain realignment, and restoration of normal or near normal function of the injured part. Closed reduction is a non-surgical manual realignment of bone fragments to their previous anatomic position. Traction and countertraction are applied manually to the bone fragments to restore position, length, and alignment. Closed reduction is usually performed while the patient is under local or general anesthesia. And after reduction, traction, casting, external fixation, splints, or orthoses or braces immobilize the injured part to maintain alignment until healing occurs. An X-ray confirms a complete transverse break of the right radius and an oblique fracture of the right ulna. LG is scheduled for an immediate debridement and open reduction repair of these fractures. How do you explain this? An open reduction is the correction of bone alignment through a surgical incision. It usually includes internal fixation of the fracture with the use of wires, screws, pins, plates, intramedullary rods, or nails. The main disadvantage of this form of fracture management are the possibility of infection, the complications associated with anesthesia, and the effect of pre-existing medical conditions such as diabetes. If open reduction with internal fixation, ORIF, is used for intra-articular fractures, early initiation of range of motion of the joint is indicated. Machines that provide continuous passive motion to various joints, such as the knee and shoulder, are used to prevent extra-articular or intra-articular adhesions. The use of CPM results in faster reconstruction of the subchondral bone plate, that is the bone plate underneath the cartilage, more rapid healing of the articular cartilage, and decreased incidence of post-traumatic arthritis. ORIF facilitates early ambulation that decreases the risk of complications related to prolonged immobility. Traction is used for the purpose of preventing or reducing pain and muscle spasm associated with low back pain or cervical sprains such as whiplash, to immobilize a joint or part of the body, to reduce a fracture or dislocation, and to treat a pathologic joint condition such as a tumor or infection. Traction devices apply a pulling force on the fractured extremity to attain realignment, while countertraction pulls in the opposite direction. The two most common types of traction are skin and skeletal traction. Skin traction is short-term, generally 48 to 72 hours, until skeletal traction or surgery is possible. Tape, boots, or splints are applied directly to the skin to maintain alignment, assist in reduction, and help diminish muscle spasms in the injured extremity. The traction weights are usually limited to 5 or 10 pounds. Pelvic or cervical skin traction may require heavier weights applied intermittently. In skin traction, assessment of the skin is a priority as pressure points and skin breakdown may develop quickly. Assess key pressure points every 2 to 4 hours. Bucks traction is a boot that is used to immobilize the fracture, prevent hip flexion contractures, and reduce muscle spasms. Skeletal traction generally is in place for longer periods than skin traction and is used to align injured bones and joints or to treat joint contractures and congenital hip dysplasia. It provides a long-term pull that keeps the injured bone and joints aligned. To apply skeletal traction, the physician inserts a pin or wire into the bone, either partially or completely, to align and immobilize the injured body part. Weight for skeletal traction ranges from 5 to 45 pounds. The use of too much weight can result in delayed union or non-union. The major disadvantages of skeletal traction are infection in the area of the bone where the skeletal pin is inserted and the consequences of prolonged immobility. When traction is used to treat fractures, the forces are usually exerted on the distal fragment to obtain alignment with the proximal fragment. One of the more common types of skeletal traction is balanced suspension. Fracture alignment depends on the correct positioning and alignment of the patient while the traction forces remain constant. For extremity traction to be effective, forces must be pulling in the opposite direction, countertraction. Countertraction is commonly supplied by the patient's body weight or by weights pulling in the opposite direction and may be augmented by elevating the end of the bed. It is imperative to maintain traction continuously and keep the weights off the floor and freely moving through the pulleys. So what type of immobilization would you expect LG to return from surgery with? He most likely will have a bivalved or split cast wrapped in an ACE bandage. This type of cast allows visualization of the surgical incision and expansion for any potential postoperative swelling. A cast is a temporary circumferential immobilization device. Casting is a common treatment following closed reduction. It allows the patient to perform many normal activities of daily living while providing sufficient immobilization to ensure stability. Cast materials are natural plaster of Paris, synthetic acrylic, fiberglass-free, latex-free polymer, or a hybrid of materials. A cast generally incorporates the joints above and below the fracture. Immobilization above and below the joint restricts tendon and ligament movement, therefore assisting with joint stabilization while the fracture heals. To apply a cast on an extremity, the affected part is first covered with a stockinette that is cut longer than the extremity. Padding is then placed over the stockinette with the bony prominences given extra padding. If plaster of Paris casting material is used, it's usually immersed in warm water, then wrapped and molded around the affected part. The number of layers of plaster bandage and the technique of application determine the strength of the cast. The plaster sets within 15 minutes so the patient may move around without difficulty. However, it's not strong enough for weight bearing until about 24 to 72 hours after application. The decision about weight bearing is determined by the physician. A fresh plaster cast should never be covered because air cannot circulate. Heat builds up in the cast and may cause a burn, and drying is delayed. Avoid direct pressure on the cast during the drying period. Handle the cast gently with an open palm to avoid denting a cast. Once the cast is thoroughly dry, the edges may need to be pedaled to avoid skin irritation from rough edges and to prevent plaster of Paris debris from falling into the cast and causing irritation or pressure necrosis. Several strips or petals of tape are placed by the healthcare provider over the rough areas to ensure a smooth cast edge. Casts made of synthetic materials are being used more than plaster because they are lighter weight, stronger, relatively waterproof, and provide for early weight bearing. The synthetic casting materials, thermolabile plastic, thermoplastic resins, polyurethane, and fiberglass, are activated by submersion in cooler, tepid water. Then they are molded to fit the torso or extremity. Immobilization of an acute fracture or soft tissue injury of the upper extremity is often accomplished by use of a sugar tongue splint, a posterior splint, a short arm cast, or a long arm cast. The sugar tongue splint is typically used for acute wrist injuries or injuries that may result in significant swelling. Plaster splints are applied over a well-padded forearm, beginning at the phalangeal joints of the hand, extending up the dorsal aspect of the forearm around the distal humerus, and then extending down the volar aspect of the forearm to the distal palmar crease. The splinting material is wrapped with either elastic bandage or bias stockinette. The sugar tongue posterior splint accommodates post-injury swelling in the fractured extremity. The short arm cast is used for the treatment of stable wrist or metacarpal fractures. An aluminum finger splint can be incorporated into the short arm cast for concurrent treatment of phalangeal injuries. The short arm cast is a circular cast extending from the distal palmar crease to the proximal forearm. This cast provides wrist immobilization and permits unrestricted elbow motion. The long arm cast is commonly used for stable forearm and elbow fractures and unstable wrist fractures. It's similar to the short arm cast but extends to the proximal humerus, restricting motion at the elbow and the wrist. Direct your care in supporting the extremity and reducing the effects of edema by maintaining elevation of the extremity with a sling. However, when a hanging arm cast is used for a proximal humerus fracture, elevation or a supportive sling is contraindicated because hanging provides traction and maintains fracture alignment. When a sling is used, ensure that the axillary area is well padded to prevent skin excoriation and maceration associated with direct skin-to-skin contact. Placement of a sling should not put undue stress on the neck. Encourage movement of the fingers unless contraindicated to enhance the pumping action of vascular and soft tissue structures to decrease edema. Also encourage the patient to actively move non-immobilized joints of the upper extremity to prevent stiffness and contractures. The body jacket brace is used for immobilization and support for stable spine injuries of the thoracic and lumbar spine. The brace goes around the chest and abdomen and extends from above the nipple line to below to the pubis. After application of the brace, assess the patient for the development of superior mesenteric artery syndrome, otherwise called cast syndrome. This condition occurs if the brace is applied too tightly, which results in compression of the superior mesenteric artery against the duodenum. The patient generally complains of abdominal pain, abdominal pressure, nausea, and vomiting. Assess the abdomen for decreased bowel sounds. A window in the brace may be left open over the umbilicus. Treatment includes gastric decompression with an NG tube and suction. Assessment also includes monitoring respiratory status, bowel and bladder function, and areas of pressure over the bony prominences, especially the iliac crest. The brace may need to be adjusted or removed if any complications occur. Injuries to the lower extremity are often immobilized by a long leg cast, a short leg cast, a cylinder cast, a Roberts-Jones dressing, or a prefabricated splint or immobilizer. The usual indications for applying a long leg cast are an unstable ankle fracture, soft tissue injuries, a fractured tibia, and knee injuries. The cast usually extends from the base of the toes to the groin and the gluteal crease. The short leg cast can be used for a variety of conditions, but is primarily used for stable ankle and foot injuries. A cylinder cast is used for knee injuries or fractures, extends from the groin to the malleoli of the ankle. A Robert Jones dressing is composed of bulky padding materials, absorption dressing and cotton sheet wadding, splints, and an elastic wrap or bias cut stockinette. The spica cast is now mainly used for femur fractures in children. The purpose of the hip spica cast is to immobilize the affected extremity and the trunk securely. The spica cast extends from above the nipple line to the base of the foot, is a single spica, and may include the opposite extremity up to an area above the knee, a spica and a half, or both extremities would be a double spica. After application of the lower extremity cast or dressing, the extremity would be elevated on pillows above the heart level for the first 24 hours. After the initial phase, a casted extremity should not be placed in a dependent position because of the possibility of excessive edema. Following cast application, observe for signs of compartment syndrome or increased pressure, especially in the heel, anterior tibia, head of the fibula, and malleoli. This increased pressure is manifested by pain or burning in these areas. This is a picture of the various types of casts. A prefabricated knee and ankle splint and immobilizers are sometimes used in many settings. This type of immobilization is easy to apply and remove, which permits close observation of the affected joint for signs of swelling and skin breakdown. Depending on the injury, removal of the splint or immobilizer facilitates range of motion of the affected joint and a faster return to function. An external fixator is a metallic device composed of metal pins that are inserted into the bone and attached to external rods to stabilize the fracture when it heals. It can be used to apply traction or to compress fracture fragments and to immobilize reduced fragments when the use of a cast or other traction is not appropriate. The external device holds fracture fragments in place similar to the surgically implanted internal device. That's an example of hand external fixation and knee external fixation with pins in the femur and the tibia. The external fixator is attached directly to the bone by percutaneous transfixing pins or wires. Looks like an erector set. External fixation is often used in an attempt to salvage extremities that otherwise might require amputation. Because the use of an external device is a long-term process, ongoing assessment for pin loosening and infection is critical. Infection is signaled by exudate, erythema, tenderness, and pain, and may require removal of the device. Instruct the patient and caregiver about meticulous pin care. Although each physician has a protocol for pin care cleaning, half-strength hydrogen peroxide and normal saline is often used. Internal fixation devices, that is, pins, plates, intermedullary rods, and metal and bioabsorbable screws, are surgically inserted to realign and maintain bony fragments. These metal devices are biologically inert and made from stainless steel, vitalium, or titanium. Proper alignment is evaluated by X-ray studies at regular intervals. Electrical bone growth stimulation is used to facilitate the healing process for certain types of fractures, especially when there is non-union or delayed healing. The mechanism of action of electric bone stimulation may include increasing the calcium uptake of the bone, activating intracellular calcium stores, and increasing the production of bone growth factors, that is, the bone morphogenic protein. Non-invasive, semi-invasive, and invasive methods of electrical bone growth stimulation are used. Non-invasive stimulators use a direct current or pulsed electromagnetic fields to generate a weak electrical current. Electrodes are placed over the patient's skin or cast and are used 10 to 12 hours each day while the patient is sleeping. Semi-invasive or percutaneous bone growth stimulators use an external power supply and electrodes that are inserted into the skin and into the bone. Invasive bone growth stimulators require surgical implantation of a current generator in an intramuscular or subcutaneous space. The electrode is implanted in the bone fragments. What type of medication would you expect the healthcare provider to order for LG postoperatively? And what vaccination should he have received in the ER if he were not up to date? You would expect the medications to be ordered to be analgesics, antibiotics, and muscle relaxants, and he should have a tetanus toxoid. Nowadays, they're giving tetanus, pertussis, and diphtheria as a combination. Patients with fractures experience varying degrees of pain associated with muscle spasm. Central and peripheral muscle relaxants such as cariprazole, Soma, cyclobenzaprine, Flexeril, or methocarbamol, Robaxin, may be prescribed for relief of pain associated with muscle spasms. In an open fracture, the threat of tetanus can be reduced with tetanus and diphtheria toxoid or tetanus immunoglobulin for a patient who has not been previously immunized. Bone-penetrating antibiotics such as cyclosporin, Kefzol, and Ancef are used prophylactically before surgery. What will you teach LG about his nutritional needs related to bone healing? Proper nutrition is an essential component of the healing process in injured tissue. An adequate energy source is needed to promote muscle strength and tone, build endurance, and provide energy for ambulation and gait training skills. The patient's dietary requirements must include adequate protein, so at about 1 gram per kilogram of weight a day, vitamins, especially B, C, and D, and calcium, phosphorus, and magnesium to ensure optimal soft tissue and bone healing. Low serum protein levels and vitamin C deficiencies interfere with tissue healing. Immobility and bone healing increase calcium needs. 3 well-balanced meals a day will usually provide the necessary nutrients. The well-balanced meal should be supplemented by a fluid intake of 2 to 3 liters a day to promote optimal bladder and bowel function. Adequate fluid and a high-fiber diet with fruits and vegetables will prevent constipation. If immobilized in bed with skeletal traction or in a body jacket brace, instruct the patient to eat 6 small meals so as not to overeat and thus avoid abdominal pressure and cramping.